everyone for being here this afternoon. I'm excited. I get to introduce our new Assistant Commissioner responsible for Medicaid. Prior to that, I'm Paul Fleissner with Health Management Associates here in Minnesota. Prior to joining Health Management a couple years ago, I've worked in the Minnesota Health and Human Service System for about 39 years, many of those years, 28 at Olmsted County. But I'm excited to have John here as our new leader around Medicaid. Just to give you a little background on John, he was a chief strategist in LA County for the Department of Public Health. What does that mean? We all know that LA County is bigger than our state. But he was responsible for Medicaid services, health facilities, homeless and emergency response. Prior to that, he was Deputy Secretary for Behavioral Health for California, HHS. He also worked in a nonprofit around healthcare coverage. One of the more interesting things I learned about him last night is he's a middle school teacher. So he's got the patience to work with all of us. So anyway, that's definitely a good part of his resume. Anyway, with that, John's going to do some opening comments. We're going to do a little question back and forth, but we're going to leave time for questions from you so you can talk to John today, because we're really glad to have him with us. John, welcome.
Thank you. It's wonderful to be here and wonderful to be in Minnesota. As Paul said, I spent the last 11 years in California, but though I came to you most recently from there, I'm originally from Dubuque, Iowa, so this is actually a return to the Midwest for me. Things have come full circle, but it's wonderful to be in a state where I can do this work and have a job like this, because I've been really impressed by what I've found here in Minnesota. I think it reflects decades of really important work and investment, I'm sure by a lot of people in the room, certainly by our team at DHS and the leadership there, and folks at the Healthcare Administration, to build really impressive programs. Medical assistance has state plan benefits. We talked about medical respite yesterday, for example. We have housing stabilization as a 1915I. We have a nation-leading model in MSHO, among other things, many other things, the SUD services waiver. So lots of really impressive work has been done here, and I've noticed it right away. In addition to Minnesota Care, which is also one of our key Minnesota healthcare programs, which is very rare. We're one of 2 states with a basic health program. I hear Oregon's planning to join us. But I also know and was educated that that program started before the Affordable Care Act, which again reflects the commitment, the forward-leaning nature of Minnesota and Minnesota healthcare programs. So it's a pleasure and a privilege to do the work here. And so I'm just going to give a few opening comments about some of the key things that we're working on right now within DHS, and then we'll get into some conversation. To start, I think the first priority just to remark upon is the unwind. I know that that is really key for Minnesota and for all states right now. It's the biggest impact on health coverage for us and for everybody across the country in terms of health coverage since the Affordable Care Act passed was implemented rather in 2014. We have now 1.5 million Minnesotans on Minnesota healthcare programs. That's 1 in 4 residents of this state. That's an increase of 360,000 people during the public health emergency, or a 30% increase. And all of those folks are now going through the renewal process. So we are very invested in making improvements to the system to make this as human-centered as possible and provide the least kind of burden on the workforce, which is also very stretched at this point, we recognize. And so for that work, we have 3 guiding principles. Number 1 is to keep as many people on the programs who are eligible as possible. That is really, I think, I gotta emphasize that, really to keep as many people on the programs as possible who are eligible. Number 2, of course, to comply with CMS requirements, and I'll say a bit more about that in a minute, but that obviously is an imperative that we keep central. And then third, as I said, to minimize burden on the workforce doing eligibility and enrollment work. And we're very sensitive to that, both within our team at DHS, but also among the counties and tribes doing the work with us. A few things that I have to say too about partners. So obviously we're not doing this work alone. We're doing this with many of you and folks out in the community. So want to mention many of our partners who are sharing in this workload. Certainly CMS is a key partner. The governor, lieutenant governor, and the legislature who have provided resources for this work specific to this unwinding period. Our managed care plans have been, I think, extraordinary new partners. We've partnered with them in unprecedented ways. The navigators that are out there in the community doing this work every day. Of course, our provider community within the Minnesota healthcare programs, in addition to community groups, advocacy organizations, and most importantly, enrollees and their families who are going through the process. So a few things just about improvements that we've made recently to make this process better for all who are going through it and for the workforce. Number one is outreach, so things that we haven't done before. Texts, robocalls. We're doing public awareness campaigns, things that DHS typically hasn't done before to raise awareness and focusing on communities that are experiencing particular health inequities and communities that are at particular risk of losing their coverage. In addition, we've done a lot of in-community events now that we're out of the public health emergency, so corresponding with the unwind, we're back in the community with a lot of partners and providing resource hubs and tools and one-stop shops online for folks to get the resources and information they need. I mentioned earlier managed care plans, and again, partnering with them in unprecedented ways to get information out through their pathways, through their teams, their infrastructure, and making sure that people know when their time to renew is approaching and that they're able to return their paperwork and get that done. In addition, some user-friendly ways to complete the renewal process that are new. So there's the renewal date lookup tool, again, as a way for folks to do some self-service and figure out when their date's coming. In addition, people can upload documents online. So that is a new functionality in addition to being able to renew by phone. So we're trying to be flexible, understanding that the paper-based process is less than ideal. Of course, we're committed to, in the long term or medium term, changing that so that people have an online option. More to come, stay tuned. In addition, if you have to go through the paper process, which many people do, we've streamlined that form to make it a bit more user-friendly so that folks don't have to spend so much time on it. And I want to emphasize this point. A key thing that we've actually improved is our auto-renew rate so that people don't receive a renewal packet at all in many cases. We're up above 30% at this point. We're pretty confident that we can push that higher. So more to come on that too, but I think that is a key innovation and a key advancement that we've made with the flexibilities that CMS has given us to be able to match across federal and state data sources to verify who is eligible for the programs to prevent them from having to go through a renewal process and fill out any paper and submit it or mail it back to us. I should note just two things here about the flexibilities that we have in terms of the federal government giving us waivers specific to the unwind. We have 14 of them approved from CMS. I'm proud to say that we are the second, but that's the second highest number among states. There are a couple with 15 I noticed on the CMS website, but we have 14.
You better get to work then, huh?
Right? But we have 14. And I think that reflects our commitment to making this as friendly to the user as we can at this moment and continue to make improvements. A couple other things too. The governor and legislature have provided extra resources, $36 million to counties, $300,000 to tribes, and $5 million in 2023 to our navigators to do the work. And of course, we've had to shift to Mitigation Plan 2.0, reinstating coverage for folks who may have lost it when we were redetermining based on households, now shifting to, per CMS guidance, shifting to individuals, and renewing coverage with some extensions for the kind of late fall cohorts into winter. And then next year, we'll be looking at any household with an eligible member. According to our data sources, we will renew the whole household and renew that coverage as a way to, again, maintain folks on coverage if someone is eligible. And then the last thing I'll say about renewals, of course, this is the beginning. So we are making some immediate changes now in the near to medium term, but we will embark on a longer term process to leave ourselves with a better and more person-centered enrollment and eligibility set of workflows and information systems in the future, such that this is less onerous for people to go through when they are renewed, but also for our workforce doing that work. So wanted to say that. A couple of additional things before I turn it back to Paul. I just wanted to mention a few things that are really important that are coming in terms of policy change. Much of this may not be news to folks in the room, but I feel like it's important for us to celebrate these wins for the people of Minnesota and also for equity. I think number one, continuous eligibility for kids 0 to 6, and then that's 72 months of continuous eligibility and a year of continuous eligibility up to age 20 is coming as well. And that's important to prevent costly and unnecessary disruptions in care. And I should note that's going to benefit 600,000 kids in Minnesota. And of course, we provide coverage for a majority of Black kids in this state, for a majority of American Indian kids in this state, and a majority of Latino kids in this state. So this is really important, I think, as an equity step forward, an equity-focused step forward, and look forward to seeing that. In addition, we're expanding coverage to people who are undocumented in this state, who represent 17.6% of people who don't have health insurance right now. So that's another step forward in that regard toward equity and expanding coverage. The state will also provide public coverage to former foster youth who were eligible for Medicaid when they turned 18 in other states. And that's a group with particular vulnerabilities that we're also really excited about extending coverage to. A couple more things related to benefits specifically. We're restoring adult dental coverage. So that is a huge step forward again. That also includes a rebasing of those rates to get closer to cost or to more accurately reflect current costs with an inflation factor in that as well. Doulas will also receive higher reimbursement rates and will be no longer subject to a supervision requirement, which is another important equity step forward as we look at trying to eliminate inequities, racial inequities in perinatal outcomes and infant mortality. So looking forward to that too. The last thing I'll mention quickly also is that we are exploring right now actively a pre-release 1115 waiver to provide services while folks are in the last 90 days of incarceration, and then providing real robust connection to community-based services with a particular focus on people with substance use disorders. And we're motivated, of course, by equity, as I've said, but also I think the intolerable rates of overdose and overdose deaths that folks experience after being released from incarceration and reentering the community. So we're all very excited, I think, within state government about that project, working with partners within DHS, of course, on the behavioral health side, but also with our partners at the Office of Addiction and Recovery. So a lot to come there, but just wanted to share that with you all as something to look forward to. So with that, I'll pause.
That's a lot to chew on. Thank you, John. One of my questions that comes up continuously is rates. How do you envision creating a sustainable healthcare system given Medicaid rates and things like workforce pressures, growing programs, et cetera? I know it's a budget issue, and I'm wondering if, I know you've only been here 2 months, but as you think about that going forward and making a sustainable healthcare system, have you had conversations, and what are you thinking going forward?
So there is a budget process, so that is something that we'll have to go through. There was a study done as well with recommendations, and so we are having those conversations. And as I said, there is a budget process for that to be kind of digested through. But want to recognize the importance of the question and that access requires rates that not only cover provider costs, but that also within the safety net get us somewhere closer to what Medicare would pay, if not what Medicare would pay, or closer to what commercial rates would pay. We can't constantly have this system where certain people have access and certain people don't, and the group of people who have a certain type of insurance are from different groups than people who have public insurance. And so that's something I think that is always a goal, to make sure that we have equitable access, and rates are a key part of that equation.
Thank you, John. I have one more question, and I'm going to start taking questions from the audience because I know they want to talk to you. To the extent possible, how do you see the Medicaid program evolving in terms of flexibility and quality assurance in Minnesota?
So I think 3 things animate my approach to the work, and I think this mirrors both the department's outlook at this point and the outlook of our team within the healthcare administration. I think innovation is a key value, and so that means flexibility and looking at ways we can do things differently. The 14 waivers that we've obtained from CMS related to the unwind, I think, is a good example of that. So we're always looking for new and innovative ways to do things. And the pre-release waiver idea that we're exploring is another good example of that. So looking for a lot of ways to do things differently, again, with the focus on service and operational excellence to make sure that we're doing the things that we're supposed to do and charged with doing in law and statute, and being good partners in that regard. I think that service means those things in addition to, as I said, equity. And I think innovation should be done in service of equity as well. We have to do things differently. I think enacting and truly manifesting equity requires some disruption. That was something a colleague of mine actually said in a meeting yesterday that I'll repeat here. And so that requires us to do things a bit differently and to be flexible.
And obviously Medicaid's a big tool toward equity, so we're glad to hear you say that. I'll open it up to the audience. Are there questions from the audience for our new leader of Medicaid in Minnesota? You stayed, so I'm guessing you have something that you're thinking about. You know, we've got a microphone coming your way.
Thank you. And you and I've connected on this a little bit, and I actually shimmied up over to Julie to ask this question, but I'll ask it to you directly. So given your experience in the behavioral health area, I was wondering how you anticipated or saw perhaps a deeper braiding between healthcare and behavioral health within the department and perhaps policy, and service delivery from that view.
Yeah, I think from within the department, I've experienced a really good partnership with our colleagues in behavioral health and the Behavioral Health Housing Deaf and Hard of Hearing Administration. I think that they are committed to working closely with us on all of the different ideas that we have in terms of advancing or innovating the medical assistance program. So I think whenever we have a state plan amendment, a waiver idea, that's going to require very close coordination between our teams. And so, and as I mentioned, the pre-release services waiver, that's another good example as an idea that we're exploring at this point. But from the very beginning, it requires deep conversation, with all the right folks in the room, folks who are from federal relations within our area, within the healthcare administration, talking about what the concepts are, and thinking through process, thinking through things like provider enrollment, thinking through things like eligibility, all of those things. So there's a cross-pollination in that regard across what we do and are responsible for, and all of the clinical and specific behavioral health things that they bring to the table as well. So it's necessary, and I think the outlook among our teams is one of collaboration, and I think we see the necessity of that.
I'll just do a follow-up since nobody else is queued up here. Do you see anything that you might bring from your experience in California to Minnesota that might amplify services here, or something that, and I know you're only like 5 days on the job, so I'm not trying to have you, but if you've observed anything, I'd love to hear it.
I mean, certainly there are things that California and other states have done, and I would say even from doing work at KFF back a decade ago, understanding the evolution of states like Oklahoma that went into managed care, went out of it, and is going back. Things that Oregon's doing that are interesting. California's got some different ideas in their 1115 waiver. But I will say, not that there's a lot of work to do no matter where you are. So I want to say that. But as I said at the beginning of my comments, I think Minnesota should be proud of how expansive its programs are and how forward-leaning they are. But certainly, I think it's always good to look at what other states have done to understand, is that going to work here, or how would we tweak it if we did it here? Or sometimes, we just have ideas and do things first, and that's fine too. But I think it's always good to kind of look around and see what's going on elsewhere, and to talk to colleagues. It's just I think it's a good kind of check of your ideas. And sometimes ideas that work well in other places, just because of how their delivery systems are structured, or particular dynamics or needs of the people they're serving, could be different. So sometimes things don't make sense, or how they're phased or structured, should be different here. So I think there are certain experiences and things I bring from the last 10 years or 11 years that could be helpful, but at the same time, some things aren't directly transferable. But I think it's going to be a conversation.
Hello, I've been at the department for 18 years, and I was just wondering if you have any plans on diversifying healthcare leadership in healthcare administration.
Thanks for the question. I think that us focusing on equity requires a team that also reflects the values of diversity, equity, and inclusion. So that's certainly, I think, a value of ours. I think it's a value within leadership in the department, and it's something that that I take seriously. So certainly that's going to be a value and I think a goal of ours as a leadership team. So I think the answer is yes. We certainly will have to hold that as a central component of what we aim to do, and making sure that all Minnesotans are part of our leadership and our workforce.
So I just want to say I've been around 18 years, and I haven't seen that happen. So I would like to see what you can do.
I appreciate that.
I think they have another over there.
Hi, Assistant Commissioner. I'm Susie Emmert from Hennepin Healthcare, the safety net hospital in downtown Minneapolis. So I know you've heard a lot about health systems and hospitals lately, and folks being in the hospital for a really, really long time, sometimes over 500 days, celebrating multiple birthdays in the hospital. And I think we would all agree a hospital is not a home. So we would love to hear from you a little bit more about what the administration is doing in this, and how we can all get a little bit more involved in helping figure that out. We know that there's a lack of capacity in the community. I don't think anybody's necessarily thinking there's a mystery to solve, but how are we going to solve it?
So I will say, I'm going to use the I'm new card on this one a little bit, but I'm going to answer the question as best as I can. So I haven't been deeply and personally involved in this challenge, but I'm aware that it is a major pressing challenge for our hospitals. And I know that Natasha Mers, who leads our Aging and Disability Services and Acute Transitions Administration, is kind of leading this effort along with the Commissioner Harpstead. And there are constant conversations about even individual cases among leadership at different facilities that we need to place in the community, and understand that finding the appropriate place for folks is a massive challenge, but it is spanning across certainly the Aging, Disability Services and Acute Transitions Administration, the Healthcare Administration, and Behavioral Health, Housing, and Deaf and Hard of Hearing Administration. All three of us have been engaged in this, and DCT I should mention too. They've also played a role in this, in creating space or trying to create additional space for folks who need to move from a general acute care hospital. So recognize this is a huge problem. It is certainly a central, I think, focus of leadership across different administrations and in leadership in the department. And so again, just want to say it's something I've heard a lot about, have not been directly involved in the conversations though, but assure you that we want to partner with our hospitals and facilities to make sure that we're doing what we can, not only to alleviate the immediate pressures that folks are under and the inappropriate placements, but also creating hopefully more capacity and better systems in the future.
Other questions? We have a couple minutes.
So just wondering how open you are to looking at adding new benefits under Medicaid, things like coordinated specialty care for, first episode of psychosis programs, collaborative care, things like that.
So I personally, I think we need to have conversations about what benefits make sense, certainly, and we do add benefits. That is something that Medicaid programs do, and certainly this one does and has done. So I think we're open to conversation about things. Of course, those items require authorization, require action of the legislature, and of course require budgetary support. So with those things being considered, I think we're open to discussion about what benefits make sense and what benefits serve people best. And certainly we have those conversations frequently with different partners, and certainly have those conversations with legislators and within the administration.
One last question. Anyone want to take the last? Okay. If not, please thank John for coming today, and wish him well as He works with us on Medicaid going forward, so thank you, John.
Thank you.